I'm going to go ahead and hit record because it is 12:30. We're so happy to see you all here. So thank you, Dr. Gahm, for setting up this journal club for us. It's been in place for several years. And just recently, I think we're saying this is a CMDA journal club. So we're very proud to have this as part of our programming. I'm Sing Pallett, president of CMDA. And today we are going to start with Dr. David Shepard, who will talk about heart failure guidelines.
Okay, let's see if I can get sharing here.
Okay.
And let's admit, yes. All right, how's that look?
Looks good. It's a beautiful first slide.
Yeah. So I want to encourage everybody to register for our April 25th conference for CMDA. We've got some great speakers, and it's always good to get together with everybody and see people that you don't always get to see and kind of hang out together. You can go to www.cmda.us and register. Or if you want, you can point your phone at the little QR code down in the right corner, and it will take you to that web page right off the bat. And I'm going to discuss the 2022 ACC/AHA heart failure guidelines. And so we're basically going to discuss HFrEF, which is heart failure with reduced ejection fraction, and HFpEF, which is heart failure with preserved ejection fraction. Many of these slides I swiped directly from the American Heart Association slide deck. I threw in some of my own as well. And we'll start with the definition of heart failure. And the universal definition of heart failure is it requires structural or functional cardiac abnormalities and at least one of the following: elevated BNP or evidence of cardiogenic pulmonary or systemic congestion. And I will, for the purposes of this discussion, interpret that to be increased left ventricular pressure. As you probably recall, there are stages and classes of heart failure. I really prefer to think of the classes of heart failure. It's just easier for me clinically. This slide kind of lines them up for us. As you see, stage C and D correspond to New York Heart Association class 2, 3, and 4 heart failure. That's probably where we spend most of our time treating patients. We maybe should be focusing kind of on stage 1 heart failure to prevent progression. We may talk about that a little bit. The classification also can be broken down based upon ejection fraction. And at the top here, HFrEF is defined by an ejection fraction less than 40%. And at the bottom, HFpEF, it is defined as an ejection fraction greater than 50%. And then there's a couple of things in between. For me, I kind of break this down along those two lines, though, HFrEF and HFpEF. And most of the other definitions, heart failure with mildly reduced ejection fraction or heart failure with improving ejection fraction, I kind of put in the HFrEF bucket. And that makes sense from a therapeutic standpoint. I think you'll see that by the end of the talk here. This is another table basically saying the same thing. The only thing I want to point out here is heart failure, HFrEF is an EF less than 40%. HFpEF, on the other hand, requires an EF greater than 50% and evidence of increased LV filling pressures. That may be an elevated BNP. It may be symptoms like orthopnea or edema or JVD. It could be hemodynamic parameters from an echo or a cardiac cath of some kind. And we all know this. This is the assessment pathway for heart failure. You'll notice that BNP and echocardiography are kind of at the heart of this. We will use those to basically put heart failure into 3 buckets here: HFrEF, HFpEF, and then everything in between. So the treatment of HFrEF, again, EF less than 40% is the definition of HFrEF. These are the 4 medication classes that we should be looking at that are define guideline-directed medical therapy for HFrEF. renin-angiotensin inhibition. And you've got 3 or 4 options here, I guess. You've got an ARNI, you've got an ACE inhibitor, you've got an ARB, and you also have Entresto, which is the combination of sacubitril and valsartan, which is a combination pill. Beta blockers, specifically carvedilol, metoprolol, succinate, and bisoprolol. And those are named specifically because they have the best data showing benefit in heart failure. Mineralocorticoid receptor antagonists like spironolactone and eplerenone. We want to monitor GFR and potassium if we're using those. And the newer kid on the block, SGLT2 inhibitors, such as dapagliflozin and empagliflozin. And these are recommended to reduce hospitalization and cardiovascular mortality, regardless of diabetes status, and actually regardless of heart failure class. So you'll see this recommendation across all 4 New York Heart Association heart failure classes. Also, still included, but kind of delegated back to symptomatic therapy is loop diuretics as needed to try to maintain euvolemia. Unfortunately, I see loop diuretics used as monotherapy sometimes, which I'm not sure that's what we want to be doing. I also see loop diuretics left on board in our population when people are falling and they're orthostatic and they're not eating, they're not drinking much. So I think we kind of want to pay special attention to loop diuretics. And if we need them, yeah, let's use them. But if we don't, it's okay to pull them off and kind of monitor their fluid status. This is basically saying the same thing. It's broadened a little bit. You'll notice the green areas here are where the evidence base is the best for drug therapy. We also should consider nitrates and hydralazine in our African American patients if the 4-drug goal-directed medical therapy is not enough. Considerations for ICDs, maybe in someone with an EF less of 35%. And as we progress along these steps here and heart failure becomes end-stage heart failure, most of our patient population probably falls into the palliative care camp once we reach significant advanced heart failure. There may be a few where cardiac transplantation or an LVAD in order to get to cardiac transplantation might be a consideration. So we should know about that. Treatment of heart failure with mildly reduced ejection fraction should look pretty familiar. It's the same as we would use for HFrEF. So I'm not going to dive into that too much more. I think you kind of see now why I have 2 buckets, HFpEF and HFrEF, and reduced ejection fraction. I kind of lump some of the other mildly reduced ejection fraction and improving ejection fraction into the same camp because the therapy's the same. Just another look at the therapy. You'll see the diuretics have the strongest evidence, rather. SGLT2 inhibitors are a close second, and then the other classes of drugs there, ACE inhibitors, renin-angiotensin inhibition, MRAs, and beta blockers. And the treatment of HFpEF. And this really deserves to talk all into itself. The more I dove into it, it was kind of a rabbit hole. This 2023 ACC expert consensus decision pathway. And this is a clickable link. So when you guys get the PDF, you'll be able to click on this and go directly to it. It was really a good review. I learned a lot from it. Some of the high points are that HFpEF is probably underrecognized. It's probably 50% of the heart failure out there. And the outcomes for HFpEF are similar to HFrEF, which is not good, right? It may be more common in women, which is kind of interesting to read about the sex differences there. Preeclampsia may predispose to HFpEF. Obesity is certainly a risk factor, which means that when we're using BNP to diagnose this, we need to take into consideration that obesity can actually lower the BNP. And BNP levels are already lower in HFpEF for the most part. So we probably are missing quite a few obese patients with HFpEF. Other things to keep into consideration with BNPs are that renal disease can raise your BNP, as can several other clinical scenarios. The risk factors for HFpEF: dyspnea, edema, older age, obesity, diabetes, hypertension, AFib. We see a lot of that. There are some mimics of HFpEF as well, such as renal disease, infiltrative cardiomyopathy, liver disease. That would be cirrhosis with portal hypertension, pulmonary hypertension, and then, of course, obesity itself. I'll just say, as far as the infiltrative disease, there's quite a bit about amyloidosis in these guidelines. I'm not going to talk about it much here. It probably deserves a talk unto itself as well. But it's certainly something we should be considering in diagnosis of heart failure. There are some scoring tools that we can use. This one is the H2FPEF score for heart failure. And again, this is a clickable link, so you can go directly to the MD Calc site when you click on this. And this scoring system looks at obesity, hypertension, AFib, pulmonary hypertension, age, and filling pressures. So we may need to actually dive into some of those hemodynamic parameters on the echocardiogram in order to use this calculator. The treatment of HFpEF is a little different. The mainstay is going to be SGLT2 inhibitors and loop diuretics. And if the person will tolerate renin-angiotensin inhibition, we definitely want to do that as well. MRA inhibitors as well, if they will tolerate it. You'll notice that beta blockers are not, at this point, generally recommended for treatment of HFpEF. However, if you've got atrial fibrillation or other reasons to utilize a beta blocker, you certainly want to do that. Again, just another way to look at the treatment. Diuretics have the highest level of evidence, followed by SGLT2 inhibitors, and then ARNIs, ARBs, and MRAs. You'll notice that the angiotensin receptor blockers are preferred over the ACE inhibitors. There's just some data showing that they may work better. You may also want to step towards four-drug therapy as a person's EF comes closer to 50%. If they start to progress towards moderately or mildly reduced EF, you may want to be more aggressive with four-drug therapy. And this 2023 ACC expert consensus decision pathway on HFpEF was pretty good, and they tend to push SGLT2 inhibitors a little harder than the 2022 recommendations, but otherwise it's pretty much the same. I thought this was interesting, so I wanted to include it. For patients with advanced heart failure and hyponatremia, the benefit of fluid restriction to reduce congestive symptoms is uncertain. And there were evidently meta-analyses of 6 RCTs comparing liberal and restricted fluid intake that didn't show much difference. No difference in mortality, heart hospitalization, sodium, creatinine. And I have seen some information saying similar things about sodium. So I guess this kind of makes me feel better about the issue. You know, at least for me in long-term care, even when I order a sodium restriction or a fluid restriction, I'm not sure that it happens, and it's really hard to have it happen in long-term care. So maybe it's not as important as we once thought it was. Hopefully it's not. And this is a summary slide kind of outlining everything that we discussed. You'll see SGLT2 inhibitors are across the board recommendations. I also included some summary slides here, or supplementary slides. And I'm hoping this may be helpful. Evidence of LV filling pressures. We all know the clinical signs and symptoms: orthopnea, JVD, hepatojugular reflux. We talked a little bit about BNP and the issues with that. These are a listing of some of the hemodynamic parameters on echo and on cath. I'm not going to pretend to completely understand all these, but at least I have a list now that I can go to as a reference if I need to dive into the echocardiogram a little bit. This slide is for your use with chronic kidney disease. As we've mentioned, CKD will increase the BNP, so we need to keep that in consideration when we're trying to evaluate CKD or for heart failure in the face of CKD as well. And age is also kind of an issue with elevated BNP. So the BNP itself it is not as affected by age. It's not as affected as much by age as the NT-proBNP is. If your BNP is less than 100, there's pretty good evidence that heart failure is probably not what you're looking at. If the NT-proBNP is less than 300, that is probably the case as well. When you start looking at NT-proBNPs for different age classes, you need to keep in mind that there are different cutoffs for different age groups. Now, if someone's NT-proBNP is 2,000 or 1,000 even, I think this is definitely high on the differential, heart failure is. So, but it is something to keep in mind. And here's my references. Again, the HFpEF review is pretty good, so I kind of labeled that one. And there's some podcasts that are pretty good at this as well. This Cardio Nerds podcast, cardiac specific, but they're short cases, about 20 minutes. There's a bunch of them based on the 2022 guidelines. I found them very instructive. And then they're also doing a series on amyloid cardiomyopathy that they just started this month. And I believe that is it for me.
Thanks, Dave. Thanks for that great overview. And I'm glad that you included some of that non-pharmacological management information, the sodium and the fluid restrictions. Yeah. What questions do people have? I know that Dr. Reddy had reviewed this topic just about 1 year ago, and there are still a lot of questions out in the field.
I have a question. That's great, Dr. Shepard. Thank you. I was curious if you use BNP in terms of serial measurements over time to kind of monitor exacerbations, or, especially when you have someone with advanced COPD, you're trying to figure out, how much CHF versus COPD is playing a role in their breathing. And so that's kind of how I use it. But after you've updated yourself on all this info, do you use it differently?
No, I don't. And there's one of the articles in there that is specifically about BNP, and they talk about a dry BNP, which would kind of be your baseline BNP, and potentially using that like you're using it, basically to assess whether somebody's having an exacerbation or not.
I have a quick question as well. This is Vikas. How do you, I know one of the challenges is getting weights in the facility, and with the kind of managing the ebbs and flows of fluid status. Was there any guidelines and frequency of weight checks in the nursing home facility?
No, not in the things I read. There was recently, and I don't know if you guys can access this or not. There was recently a transitions of care heart failure topic that was discussed in Pulp Med, and we'll have to look and see if you guys can access that. They did talk about that a little bit. Yeah, it's really challenging. I mean, I always say one of the more challenging things in long-term care is getting an accurate weight. I mean, it seems so easy, but it's not. Obviously, in a perfect world, we want to monitor weights, and if there's 3 to 5 pound shifts, you want to start looking at their fluid status and see if that's the issue. But no, I didn't see anything specific about it, and I think we did discuss it in the that Pulp Med lecture. We'll have, if I can find it, I'll send it your way.
Sure, appreciate it. Thank you.
Dr. Lieber?
Oh, thank you. So I just wanted to follow up on the conversation for getting weights in our space. Dr. Rebecca Boxer did a huge study in SNFs and to find out whether even when we got weights consistently, did that positively affect the care of patients with heart failure. And she found that even when her own nurses through her study did the weights, and did them religiously, they were not accurate enough to affect the well-managed patient for heart failure. So even if we do get weights, I caution us to just look at that data and say that may not be the best mechanism to find out how people are doing. At least it hasn't panned out in that data. Thank you.
Yeah, and I'll just add to that, probably last year, I really started trying to push the 4-drug therapy. And, just anecdotally, I've probably used it I don't know, 5, 6 times. And I've noticed that I've been able to pull off the loop diuretic on quite a few of those people. So their symptoms get better within a couple of weeks. Um, it seems to help with that. So maybe that would be less of a concern. The weight issue would be less of a concern if we kind of push the four pillar guideline directed medical therapy a little more. We might not need to do as much tweaking with the Lasix and the diuretic.
Just one more thing, Leslie Eber again. That's also been panned out in prospective randomized control studies with SGLT inhibitors, that within 2 weeks, many people see a difference in their symptom management. They feel better, they can walk more. And so, it's not our imagination, it's really true. Thank you.
Yeah. Thanks, Liz.
In your reading, did you find out any new recommendations for GLP-4 agonist use in heart failure?
I did not. No, I didn't even look into that, to be honest with you.
Okay. And Dr. Thompson has a comment in the chat box. Maybe you were discussing that, but always struggling to choose therapy for the frail seniors. We hate to put them on 4 new medicines, and maybe in some patients might need to just focus on symptom control. What are your thoughts on 4 new medicines?
Yeah, I totally agree with that. I mean, I'm a guy who spends most of his time trying to get rid of medications, right? I agree with that. And, it even hurts a little more because the cardiologists that I listen to and that I've, read on this say that you really want to get them on all 4 if you can, and then worry about titration. There are certainly cases where, adding 4 meds to somebody is not going to be what we want to do. You may want to add an ARB. You may want to use some Lasix. There's other options here depending on the clinical situation. I will say that I think if symptom management is the goal, it's looking like this therapy will improve symptom management. So, that's something to consider too. If just using Lasix is maybe not as effective as having them on 1, 2, 3 of these drugs, maybe just an SGLT2 inhibitor and an ARB, we really want to make sure we are providing the most effective therapy, even if it is just for palliative purposes.
I did read a small study from Japan on heart failure in frail older adults. When they were following the guideline-directed medical therapy, they saw more rates of adverse effects like you would expect, more hyperkalemia, bradycardia, hypotension, falls. So we definitely have to watch for it.
Okay.
Thank you, David.
Sure.
Greg, Gahm, are you available to talk about influenza and treatment of influenza?
Yeah, I'm here. Like we talked about Tuesday, just more and more data showing that Tamiflu really is not worthwhile. And there's, I think I sent 2 articles in anticipation of today. I pulled 20 years worth of articles that I have on both the adamantines and also Tamiflu and some other stuff. But as far back as 2009, Tamiflu was completely useless for the H1N1 pandemic that we had. Remember the swine flu that lasted about 5 years. But it just doesn't really work. I mean, if you read Gau's the most recent article from JAMA Internal Medicine last month, nausea and vomiting, yeah, you get a lot of that, but you just don't reduce hospitalizations. You don't stop deaths. I think the main reason that we use it right now is to feel like we're doing something. You just feel like, got to do something. It's sort of like treating pancreatic cancer. You just feel like, got to do something, but you're not going to change the outcome, except for that 5% that have the odd pancreatic cancer. But, I wouldn't, I would counsel people not to use it, but if somebody wanted to, there are a lot of reasons to use it. It's still in the published guidelines, but you know, because they haven't caught up with the data. But anyway, that I wouldn't use it. And I think in part, the more that we use it, the more we send the message there's an option to vaccination. You know, because hey, if you get sick, we got a pill. And I think that's the wrong message to send. We really just don't have anything short of vaccination that's going to make a difference.
Can I
Yeah.
ask, Greg, you said you like it when we ask questions, so here you go.
I love it.
Yeah, did they have a large enough population of nursing home residents in this study? Or
Boy,
was it diluted somehow from outpatient?
yeah, it was probably a lot of outpatient. They actually looked at 2,352 studies. Okay, so I don't know how many million people that was, but eventually they got it down to 6,200 people, for whom 55% of them were prescribed Tamiflu, but they didn't really separate out nursing home, non. So my guess is that this is primarily community based. My own thought for Tamiflu years ago, when I thought it was useful, and also now for baloxavir, if you could start it in the first 2 or 3 hours after symptom onset, you might have a chance to make a difference. But I think, you know, by the time people test and get studies back and get called and get a call back, that 48-hour window is, you're at the tail end of it, or you're on day 3, and again, you just feel like you want to do something, and at that point, it's way too late. And again, for me, the most important reason not to use it is to send a very clear message. We don't have drugs that treat influenza.
And given the 2 indications for Tamiflu, post-exposure prophylaxis and treatment,
Yeah.
are you blending those together, or is there clarity needed?
Well, I haven't recommended using prophylaxis except for really close contacts for years, just because it does, sort of like with antibiotics, put pressure on the virus to for mutations to occur and for, you know, resistance. You know, if you can do it quickly in somebody that's really at risk, and has symptoms, maybe there's justification to go ahead and try it. But at this point, again, just for me, I would probably choose baloxavir, because at least it had some data of all these different choices that they used. They looked at, I think, 7 different agents, and baloxavir that was the only one that showed any level of improvement or significance. And most of us aren't used to using it, and as you go down the viral pathway, it's the transcriptase part that takes place in the nucleus that's going to block. And again, it's every hour makes a difference. Because you're not, again, people think we're too used to antibiotics. You think you take the pill, it's going to kill the virus. It has nothing to do with kill the virus. The only thing any of these medications do is try to prevent it from, like the neuraminidase inhibitors, you're trying to prevent the new virus that you just made inside the cell from getting out of the cell and spreading. The adamantines, we're trying to prevent it from getting into the cell to begin with. Baloxavir and peramivir, some of the others, trying to stop that step where your DNA is actually making the virus inside the cell. But again, if you wait too long, it's already spread. It only takes 48 hours to get from onset of symptoms to widespread in your lungs.
Thanks for sharing that article, Greg. I'm happy to pass it on to anyone else who would like to have a copy of it if you can't find it online. When I
Yep.
looked through the supplemental content where they're trying to break down which studies they looked at, they mentioned that they looked for high-risk patients who were being studied as well. But it doesn't seem like they were able to tease out specifically people living in long-term care. That would be important to me, obviously, because of our population, but because long-term care patients are living so close to each other and have different risk factors. They also didn't have enough, I think, to make any comment specifically on the prophylaxis for high-risk patients.
Right.
Good. Thank you for bringing us up to speed.
Sure.
Thank you both for your presentations today. We're really glad that you were all able to join Journal Club. Thank you.
Thanks, Sing.
Great to see you, Val.
You too.
Thanks, Dave. You did a great job,
Yeah, I thought that was really good.
as usual.
Yep, thanks. Yeah, so we basically have a vaccine that's 30 to 50% efficacy in our population, and we have drugs that are maybe some, probably none. So,
Probably.
Right.
yeah,
That's
so that might be my new selling point.
Yeah.
What's your selling point? The vaccine or just?
Yeah, I don't know that I have ever made like a direct comparison for people like that when we talk about why you should get vaccinated. You know, I certainly did with COVID. I don't know why I wouldn't do it with influenza, but
Okay.
probably
and-
should take that approach.
And I think one of the biggest mistakes we make is that we vaccinate people and their assumption is, okay, I'm never going to get this disease.
Yeah.
And then they get flu, and and they get mad at you the next year. Yeah, I got that vaccine. I got flu anyway.
Right.
And like COVID, you say, yeah, of course you did. The vaccine doesn't prevent the disease. It prevents it from getting serious once you get it, because you get a much quicker response.
Yeah, it's 2 days of feeling crummy instead of a week.
Yeah.
It is very different. I've had it both ways. It's definitely better with the vaccine. So
Yeah. And I think we'll see, well, maybe not now, given our current leadership in the government level. But I honestly think we will see high dose vaccine for the general population. I don't think it needs to be limited to seniors. Now, maybe not kids. I don't know, because they respond so quickly. But I've seen a few studies now that have looked at it in randomized, comparing it to standard vaccine in just the adult population. And the data was good that it's more effective. The argument up until about 5 years ago was that we don't have enough eggs. You just can't make enough vaccine quick enough. But now with mRNA vaccines, they're actually looking at that, and you can make it not only quicker, but you don't have to use up all those eggs.
yeah, eggs are expensive now, man.
Yeah. Anyway,
All right, thanks, guys.
well, thanks, guys.
Thank
Have a
you.
good day.
Great job. Thank you.
Bye-bye.
Bye-bye.